Thank you. Welcome, Secretary Azar. You mentioned GME in the discussion with our colleagues. How would the proposal encourage medical training in community clinics where most physicians actually care for patients, and how would it help the community clinics that are not under the current cap?
So in terms of is this the community health center program on GME that you're referring to, Senator?
Your proposal to change the structure.
So
I'm just trying to understand
Yeah.
how would it address a couple of things that are in the need area, which is
Right.
community-based clinic training and teaching hospitals that aren't under the current cap program.
Right. So we're not proposing a change to the community health center based training programs that we have. Those are separate. These are the Medicare, Medicaid, and then the HRSA run children's hospital programs on GME. And it puts those together so that we don't operate under these artificial 1996 based caps, and instead can really focus on the providers that can help train our physicians and get them to both make sure we're funding in the underserved specialties and areas where we need physicians the most to make.
Including primary care.
Absolutely, absolutely. Okay. As well as underserved areas. How can we make sure that we're dedicating the money to get training of physicians that are or will serve in areas that are lacking in appropriate physician care?
Okay, so if you're saying you're willing to take on the big behemoth of East Coast teaching institutions having most of the capacity, I'm all with you, okay? Because I think the divergence of medicine and where we're going, we need to train physicians in all sorts of ways. So I'm all for that. I don't like the fact that you've actually then cut the program, because from my estimation of what I see in the Pacific Northwest and our shortage and the whole notion of everybody having a medical home, and we're very excited about P4 medicine, preventive, prescription, personalized, so that, physicians are being trained on what you would, I hope, describe as a way to drive value into the system and get off of fee-for-service. So what about that number? Why cut the program when I'm pretty sure we need probably like 4 or 5 times that amount?
Well, the overall, one of the philosophies that we had was to try to move some of our programs where right now we're having Medicare carry the burden across the whole healthcare profession. As we look to how can we make Medicare be more sustainable, our proposals actually stretch out the life of the program for another 8 years as a result of it, and it's tough choices, I will admit that. But right now we're having Medicare and Medicaid fund graduate medical education that private insurers, commercial people get the benefit of. And so there's a bit of recalibrating in there that from the federal taxpayer perspective and Medicare, Medicaid, that transition to cut that back a bit. As a result, I think it's 48 billion off of where we stand right now, over 10.
But if we examined the shortage and the need, you wouldn't cry if Congress basically boosted that number.
I would have to do so within our budget targets. So if that goes up, something else has to go down. That's the age-old challenge of these budgets.
Okay. Well, please mark me down as very counter to what Senator Toomey just said. I believe that we have a growth in our Medicare and Medicaid population because we have a burgeoning baby boomer population that's reaching retirement. So the notion that somehow people think that you should cut Medicaid and Medicare or block grant Medicaid as a way to save dollars just because the population is growing because of the demographics in our population, I just think is wrong-headed. Now, do I think there's efficiencies? You and I have had a chance to talk about rebalancing as one of those. That's a huge, huge savings. But the notion that somebody, after giving away billions of dollars in tax breaks to big corporations, want to come here and say, now we have to block grant Medicaid as the only solution because it's growing in numbers because of demographics, is just, I just don't agree with it. As my providers have told me, hospitals, they view the block granting proposal as nothing but a budget mechanism to cut Medicaid. So what they do support is the efficiencies that we're driving in the Northwest and implementing those in the system, which are driving, who doesn't want to stay at home and get long-term care? My colleague just mentioned. Who doesn't want to do that? That is 1/3 the cost. And so if you could comment on rebalancing from nursing home care to community-based care as a big savings.
That, for some individuals, institutional nursing home care meets their needs and is what they need. But I am, as I said at my confirmation hearings, a firm supporter of the notion of home-based care and these alternative ways. I believe it can save us money. I believe that for many it can be the best solution. It can be the way to age with dignity. So I am very supportive and very much want to work with you on ways we can generalize that more across the United States.
Well, I appreciate that. I just very concerned about some of my colleagues. We've been very suspecting that this is what might happen now after the tax bill passes, that people are going to go back to trying to block grant Medicaid, and just mark me down as very opposed, and basically a much better, we're already doing the job. We're already doing the job of reducing the cost. So the notion that somebody wants to create a budget mechanism to cut people off Medicaid, my providers, the community services, the children's, they're just not going to support it. Thank you, Mr. Chairman.